the third most common cancer in the U.S. and the second deadliest. More than 132,000 new cases are going to occur this year, and close to 50,000 deaths. Also important is the fact that incidence and mortality are higher in many Native American and Alaska Native tribes. It depends in part, at least, on geography for some unclear reasons. And also it's important to recognize that incidence and death rates from colorectal cancer have fallen steadily over the past 20 years for most groups, although, again, many Native American and Alaska Native groups have not seen that same sort of fall, unfortunately. This decline in both incidence and mortality is related to a couple of things. One, the fact that we're able to treat this disease much more effectively, but screening has played a huge role. Screening is important because although there is a preventive element to screening, even if you miss that opportunity, finding the disease early makes a huge difference. This slide shows the 5-year survival rates for people diagnosed with colorectal cancer by various stages. On the left, the blue bar are people whose disease is localized at the time it's diagnosed. That is, it is not spread through the colon wall. 9 out of 10 of those people are going to be alive 5 years later. If you contrast that with people who have metastatic disease that spread to other organs, that's the red bar, only 10% of those people are going to be alive. So 90% versus 10% survival. And any number of studies have shown that you're much more likely to be diagnosed early if you are up to date with colorectal cancer screening. So improvements in treatment, screening leading to early detection, big factors, but screening leading to finding and removing adenomatous polyps, kinds of polyps that can turn into colorectal cancer, actually prevents the disease. So this is one of the very few screening tests that we have in cancer where we not only find disease early and treat it more effectively, but maybe more importantly, we prevent cancer from ever occurring. Researchers at the American Cancer Society estimate that over the last 3 decades, we have prevented more than 500,000 cases of colorectal cancer by finding and removing polyps. So screening is huge, plays a tremendous benefit. So how are we doing in terms of getting folks screened? Well, who should be screened? Everybody who's 50 and older, and this graph shows exactly why. If you look, actually, beginning in your 40s, the likelihood of colorectal cancer begins to go up, but it begins to go up very dramatically by about age 50. This is why screening recommendations from every major medical organization recommend that screening for colorectal cancer begin at 50 for the average risk population. For people who have increased risk because of a family history or inflammatory bowel disease, those folks need to start screening earlier, and there are separate guidelines for those individuals, and I'll mention them a little later as well. So how are we doing in terms of getting everybody screened? As of 2012, according to data from the CDC, about 65%, so basically 2 out of 3 adults 50 and older were up to date with screening. The rates are higher in the older population, those between 65 and 75, about 3/4 of those, or 3 out of 4 people, Medicare removing financial barriers. It's clear, though, that not every group is getting the same level of care. Hispanics and Native Americans in particular have significantly lower rates of colorectal cancer screening, as does anyone of any race or ethnicity if they're uninsured. So what's keeping screening rates down? Well, in addition to the barriers that I just talked about, race, ethnicity, socioeconomic status, insurance status, there also are a number of factors within the healthcare environment. For one, medical practice is demand-driven, and there just aren't that many patients coming in demanding colorectal cancer screening. They come in with concerns because their back hurts, or they're having flare-up of their arthritis in the knee, or they need their blood pressure checked, or their sugar under control. But they're not coming in asking for screening. And very few practices currently have mechanisms in place to make sure that all at-risk patients are identified and get screened for colorectal cancer. Now, we do this for other things, and frankly, many practices do a much better job, for instance, with breast cancer screening than colorectal cancer screening. There is also an over-dependence on the clinician, that is, on physicians and mid-levels, to remember with each and every patient to assess their current screening status and make that order. And that's really not necessary for many, many patients if you build the right systems in. There's a focus on colonoscopy. Indeed, in many practices, colonoscopy is the only tool that's recommended, and I'll show you some evidence about why that may not be the best approach. And then finally, there's a failure to address patient concerns about colorectal cancer screening. What we do know is that colonoscopy is by far the favorite tool. Nearly 9 out of 10 screenings in the U.S. in the last year, indeed over the last 5 years, have been with colonoscopy. The second choice is stool occult blood testing, and there are two kinds of tests that look for hidden blood in the stool, that being guaiac-based fecal occult blood test and fecal immunochemical test, or what are known as FIT tests. About 8 to 10% of screening in the U.S. occurs using these kinds of tests. Both of these tests work the same way. That is, they look for evidence of hidden blood in the stool. There are many, many brands of both guaiac tests and many brands of FIT tests, and all brands aren't created quite equally, but right now we don't have any really good information to say use this test, not that test, but work is underway to try to make that a little more clear as to which of these tests work most effectively, at least when it comes to FIT. With regard to the guaiac test, it is clear that the test pictured here, Hemoccult Sensa, is a high sensitivity guaiac test and is much, much better at detecting colorectal cancer and polyps than older versions like Hemoccult 2. So if you're using Hemoccult 2 or another older version of guaiac testing in your practice, you want to switch to Hemoccult Sensa or switch over to a FIT test. Now, I mentioned the fact that patient preferences aren't taken into account. Well, there's a body of evidence that's growing and demonstrating that although clinicians strongly favor colonoscopy for screening, patients don't always feel that way. This is a study that was done a couple of years ago in a safety net population. They looked at about 1,200 patients, all of whom needed colorectal cancer screening. And one group was told, go get a colonoscopy. A second group was told, take these stool kits home and collect stool specimens and bring these back. And then the third group was told, colonoscopy works, stool testing works, you choose. What they found was the folks who were only offered stool testing, 67%, or basically 2 out of 3 patients, completed that testing within the study period, compared to only 38%, less than 4 out of 10 patients were given a choice. Again, 2 out of 3 of those patients completed testing. Now, this is just one of a number of studies that have looked at this issue and found over and over again that somewhere between a third to up to half of patients, if given a choice, will actually choose stool testing over colonoscopy. Yet, when you look at what patients are actually being offered, you find that even patients who've refused colonoscopy or who have repeatedly failed to follow through when colonoscopy was recommended are very rarely offered stool testing. There also is a lot of data demonstrating that clinicians are not aware of the advances that have been made in higher quality stool testing, and many clinicians still don't even know that a fecal immunochemical test, a FIT test, exists, let alone that it's much more sensitive and specific than our older tests like Hemoccult 2. So we clearly need to do some work to increase the use of stool testing, and particularly FIT testing, in primary care environments. It's important that stool testing, if it's done, be done correctly. And one of the failings that we often see is physicians or other clinicians doing a digital rectal exam while the patient's in the office and then smearing whatever mucus or small amount of stool on a card and calling that colorectal screening. It's been demonstrated by some very elegant studies that that is a very, very poor approach to colorectal cancer screening. Indeed, the one study that looked at this most closely found that doing a digital rectal exam missed 9 out of 10 cancers that were subsequently found during colonoscopy. So 9 out of 10 patients who had cancer had this test done, were told it was normal, and would have been sent home. if that was the only testing done. So in-office testing from a digital rectal exam should never be done. That's just not good colorectal cancer screening. Screening should be with high quality, high sensitivity tests like Hemocult-Sensa or FIT. It needs to be repeated annually because even high quality tests are going to miss cancers and many polyps. And then finally, every positive test has to be followed with colonoscopy. So it is not enough to tell a patient, well, you may have not followed the diet correctly, or we should have stopped your aspirin, or some other reason. If you have a positive FOBT or FIT, that patient needs to have a colonoscopy because they have cancer until proven otherwise. All of this information is summarized in this one-page document, one-page front and back, that you can download from the American Cancer Society website. So let's talk about the Flu-FOBT program. So FOBT is an effective approach to colorectal cancer screening. It has to be repeated annually, as I stated. Now, many patients are accustomed to coming in annually to get their flu shots. And as a matter of fact, I mentioned earlier, very few patients come in demanding stool testing or demanding colorectal screening, but many do come in and ask for their flu shots. So why not take advantage of that patient who is already in a wellness mode and doing something every year and build on another annual preventive kind of test? So basically you either work this into your workflows, or if you're offering flu shots through a flu clinic, then you work this into that flu clinic environment. But it's important, as already mentioned, that the patient take this kit home and collect their stool specimen. A number of studies have demonstrated that this is very well accepted by patients. There are a lot of sites that have begun using the Flu-FOBT approach in order to get their staff accustomed to doing high-quality FOBTs and break it into the practice setting. So basically, in order to put one of these programs together, you have to pull together a team. You need a champion, and that champion does not have to be a clinician. It can be a medical assistant who's highly motivated, or a nurse, a nursing assistant, but someone who's going to take responsibility for coordinating all of this and getting the buy-in from everyone else on the staff. So you need to have team members who are involved in each step of the patient process, everything from the front desk to whoever's going to send that patient home when it's all done. And if you have a lab on site, also making sure the laboratory people are engaged. You need to train your team. Everyone needs to understand how you're going to organize the workflow to make this happen within your practice. You need to make sure that eligibility is assessed because not every patient is eligible for this. You also need to have some clear talking points and patient education materials related to both FOBT and appropriate test completion. And someone's got to keep track of all of this. So you have to choose exactly how you're going to put this together, when you're going to start with your Flu-FOBT program, and the recommendation is that you start doing your training during the summer, so by the time you start giving flu shots in September or early October, everyone is ready to go. And you also have to figure out how you're going to advertise this. You want to make sure that patients are aware that you're offering this new service and that they can understand the benefits associated with this. Now, who should be offered who should become part of the Flu-FOBT program from the patient side? Everyone over the age of 50, as I already mentioned, who has not had an FOBT in the past year or a colonoscopy in the past 10 years. If someone's had a normal colonoscopy, they do not need to be tested for another 10 years, so you don't want to over-test. But who shouldn't be offered is equally important. You don't want to offer this to patients under 50. You don't want to offer this to folks who've already been screened, but those high-risk patients that I mentioned earlier, people with a history of Crohn's disease or ulcerative colitis, people with a personal history of polyps or colorectal cancer, people with a family history of adenomatous polyps or colorectal cancer, or anyone who's having rectal bleeding. All of these patients fall into a higher risk group, and FOBT or FIT screening is not appropriate for them. There are separate guidelines for high-risk individuals. So these patients need to be referred to the clinician and go through high-risk screening, or in the case of rectal bleeding, diagnostic evaluation. Again, with regard to the program, up front, you want to have done a lot of planning and pulled together the right kind of material so that patients have clear instructions. They understand, one, why colorectal screening is important, but two, they have instructions that help them know exactly how to collect the specimen based on the kits that you're going to be distributing, having return envelopes so that patients don't have to make an extra trip back to the clinic just to turn those in. Reminders are extraordinarily important. Having postcards or having a phone call script on hand, and having made arrangements for the follow-up care. A relatively small proportion of patients will end up with a positive FIT. In most instances, it's somewhere in the 6 to 8% range. So that 6 to 8 out of every 100 patients that you give one of these kits to is going to have a positive. But those positives, as already stated, need a colonoscopy, so knowing where your resources are. As just previously mentioned, educating your patients. One of the important things to recognize is many people are given FOBT kits in the course of primary care treatment, but if all you do is hand out the kit and tell patients you need to collect some stool specimens, if they don't really understand the reasons why, they're not necessarily going to be compliant. So putting some time into educating patients and letting them know how important this is for them and the potential benefit for them. And then the other thing that's been shown in a number of studies is for those patients who don't return those kits, if you reach out to them within 7 to 10, 14 days maximum after they're given those kits, with either a phone call, a postcard, or nowadays people are using text messaging or emails. But reaching out to them and reminding them can double your return rate. So building that into your FluFit program is important. Now, I've kind of zoomed through a lot of very important information, but all of this is summarized in this implementation guide that you can download from the ACS website, and I believe you'll be getting a handout with this information as well. And this is the kind of information that's included in the implementation guide, but my whole presentation really is just a brief summary of the information that's included there. So I will now pass this back. Well, hopefully somebody there can take over control because I'm not sure how to pass it back. Great.
Thank you, Dr. Brooks. At this time, I'd like to introduce Dr. Kevin English. Dr. English, you're on.
Okay, well, thank you very much. It's a pleasure to be part of this panel this afternoon, I assume in most places. And thank you, Dr. Brooks, for your presentation as well. So my presentation is going to be a little bit different. It's not explicitly focused on FluFit. Rather, it's a new approach that we took here in the Albuquerque area to trying to boost colorectal cancer screening within several tribes here in our area. But before I go too far into the intervention approach that we took, I just wanted to make sure that everybody was on the same page as to who we are. So we're one of 12 tribal epidemiology centers located across the country. And you can see here on this map which particular tribal epidemiology center serves the American Indian community or Alaska Native community in your area. And so I hope that you reach out or you're already partnering with your tribal epicenter. But if you're not familiar with the work that we do, our services are really organized around several domains. As you could probably imagine from our name, epidemiology, we do focus quite a bit on data and surveillance. But we also recognize in our work with tribal communities and presenting to tribal leaders that there is a desire for us to take information that we gather and that we package on behalf and for the tribal communities that we serve to really take it to the next level and translate that information into action. So although our name says Tribal Epidemiology Centers, many of us are involved in health promotion, disease prevention, intervention, including cancer control. And so what we do often is we weave together the data along with sort of activities that are aligned with the priorities that emerge from the data that we're seeing. And so when we look at cancer here in the Southwest, and we look at the different types of cancer that are most common among the American Indian population here, it doesn't look much different than the national population in terms of the most common types of cancer. So colorectal cancer shows up as the second most common type of cancer for American Indian males and females here in New Mexico, at least. And then when we look at cancer mortality, and this is where we have some disturbing trends based on those that are circled here, you can see that, you know, those particular types of cancers that we do have screening or even prevention for, including colorectal, continue to reside towards the top of these lists. So this is that sort of leverage point for intervention that we identify. And when we talk to tribal leaders and health program administrators and community members, there's a real desire for us to be involved in the process of moving this information into action. And so what I wanted to share with you today is a little bit of an approach that we're taking, because when we looked a little bit deeper, we found that more than half of the colorectal cancers that are diagnosed among American Indians in our area are actually at later stages. And Dr. Brooks already showed you the impact that that has on survivability. And so when we looked a little bit closer at how we were doing with screening, we realized that in our area, at least, we were only at about 36%, about 1/3 of American Indian men and women aged 50 to 75 are up to date with their colorectal cancer screening. And obviously this rate is not acceptable. It's trailing those national rates. It's trailing our healthy people targets for 2020. It's certainly trailing our 80 by 2018 goal as well. So we have some work to do. And so what we did was we looked at the literature to see what else was out there in terms of potential solutions for increasing colorectal cancer screening. And one that caught our attention was something that's been happening at Kaiser and with the VA system. And we've seen that sometimes just getting the kits directly to the patients who are eligible for screening can make all the difference. Sort of cutting out that whole process of a patient having to go in to a clinic, then actually have a provider provide the recommendation and the kit for the patient to take home. The patient then goes home with the kit, completes it, and brings it back. There are several steps there, right? And so one of the hopes that we had was that potentially, even in a rural tribal community, this sort of intervention that we're seeing working at systems like the VA hospitals and Kaiser Permanente might actually work. And so what we did was we worked with 3 tribes here in New Mexico, and we sort of set up a unique randomized controlled trial with our focus being on participants of eligible screening age 50 to 75 and not up to date with colorectal cancer screening, no history of colorectal cancer or previous colectomy. And what we did, rather than randomize 3 tribes into each of these study groups that you see here, we randomized the eligible population in each of the 3 communities into each of the 3 study groups. So we had all 3 study groups in each of the 3 sites that we were working with, and there are several reasons for this. First and foremost, from an ethical standpoint, the tribal IRBs in our area, the tribal communities in our area prefer not to be randomized to usual care. And so if there is an intervention that we think or that we hypothesize might have some added benefits, they want to make sure that they're being a part of that right from the get-go. And then secondly, we also wanted to make sure, should we have any attrition from a whole community in our study, that we'd still have all 3 study groups represented as we went forward. Fortunately, all 3 communities continued throughout the entire study. So just as a reminder here at the bottom, the 3 study groups were usual care. Then we went ahead and mailed the FIT kits directly to 1/3 of the eligible community members. And then in a final group, we mailed the kit, and we also had the community health representatives, or CHRs, perform some outreach on top of the mailing of the kits to see if that might make even a further impact on screening rate return. And so if you're wondering, for our mailed kits, we use the Polymedco OC Lite FIT kit. It's just a single collection test. Along with the kit, we had a letter, a personalized letter that came and was signed either by the CHR director or the clinic director or both. There was this instruction sheet, which you see here, where we tried to ramp up the imagery and the visual pictures on the actual instructions. And we even included a self-addressed postage-paid envelope that folks could mail the kit back if they chose not to hand carry the kit back to the clinic. If you're not familiar with CHRs or community health representatives, all of the tribes that we work with here have a CHR program. And in most instances, they sort of embody these characteristics that we thought were really important for the project, especially for the outreach. They're familiar with the culture and language of the community. In most cases, they are from the community that they serve, oftentimes a patient within the local healthcare system. They've often already established trust with the target population. There's certainly more understanding of some of the key sensitivities and cultural considerations with more sensitive health topics, including cancer. You know, and they really bring that peer and social support to the overall process of providing outreach and education. And finally, they're already sort of operating in this bridging role between the community and the local healthcare system. And so this was yet another opportunity to try and leverage their role into this new project. And so we did set up an outreach protocol for them, and we had several in-person trainings with the CHRs, and we all agreed upon sort of outreach in 4-week increments, beginning first with a phone call. The CHR made up to 5 attempts to call the patient who received the kit, and that began 4 weeks out of the mailing. Then they followed up with a home visit if the kit still didn't come back. The labs were in close communication with the CHR directors to let them know when kits came back so they could cross people off the list. But if they still weren't crossed off the list, the CHRs then went out and made a home visit, and up to 3 attempts in this instance. We started with the phone call to try and go with the lowest cost outreach possible. And then finally for outreach 3, we did another series of phone calls up to 5 attempts per patient. So I'm just going to share with you now some of the preliminary results that we're seeing. We're still in the middle of some of the analysis. Some of the more in-depth analysis is still happening. But our preliminary results show that overall we had a fairly low return rate in all 3 groups, but there clearly was a gradient. Usual care was hovering just about the same percentage that we had seen in all 3 communities before we started. And I mentioned these were very low screening rates already. And so in this case, our usual care group only came back around 6.4% of the time. We saw about a 2.5-fold increase in the mailed-only group, and that was a statistically significant difference, up to almost 17%. And then even higher return rate in the CHR plus the mail-out. This was certainly about 3 times the rate of the usual care, which was statistically significant. But the difference between this particular group and the mail-only did not show any statistically significant differences. A few other pieces of data, very interestingly, when we looked at the entire population to look at the return rate by gender, we saw that men and women returned the kits at the same rate, which was quite interesting. When we broke it out a little bit further, though, we found a more nuanced sort of pattern for gender, where we saw the males really preferring to mail the kits back. You know, and not to mail the kits back, to receive the mailed kits. They were more likely to respond to just the mailed kit than any other group, whereas the females, as you can see, were much more likely to respond to the mailing plus the CHR follow-up. So there was a gender difference there by study group in terms of which was more likely to elicit a returned kit by men and women. Then we also looked at age, and we did see a little bit of a gradient here as well, where as the patients were getting older, they were more likely to return the kits as well. We do have a little bit more in-depth analysis to do here to better understand these return rates. We did want to see, did it make a difference how participants return the kit? So of those who returned the kits, you can see most chose to hand deliver the kits. So in the end, we didn't really need too many pre-stamped envelopes for the patients. About 27 were mailed back, and it was evenly divided between males and females, so we can't find a specific pattern as to who's more likely to mail it back. And the CHRs did offer to take back a completed kit, and in one instance they were taken up on this offer. So when we look at some of the limitations from the get-go here, we had heard throughout the process, and we witnessed that there was a fair amount of turnover in our CHR population during the intervention period. It was over a period of 6 months. So that was somewhat discouraging in terms of we have to sort of interpret the findings with a little bit of caution. We're glad to see that there still was a slight increase over just the mailed kits. But we know from talking to the CHRs, at least anecdotally, that in many cases they really weren't able to adhere to the protocol as we had put it together due to this turnover or to conflicting job duties where they just had too much on their plate. So that's something that we need to think about going forward in terms of the outreach component. We certainly know that there's potential for contamination across study groups because they were randomized within the same community, but at the same time we're not really seeing an increase of usual care return or anybody going in and asking for a kit, you know, if they weren't in the mailed group or the mail plus the CHR group. And of course, we only worked in 3 communities here in New Mexico, so at this time we can't say that our results are generalizable to all American Indian populations. But we do have some clear next steps. We first want to make sure that we do some interviews with the CHRs to really better understand what those key barriers and facilitators were to their participation and outreach. If it's not a viable method for following up with patients, we want to find one that would be, or perhaps there's a more less labor-intensive role for the CHRs in this type of work. We also need to follow up with those participants who had a positive FIT test to just confirm that they've had their colonoscopy referrals, that they've obtained their colonoscopies and the results of their colonoscopies. We've done most of this work already. We just don't have the data to share at this time. We also are excited about this fall testing out FluFit here in our area as well. We're going to work with several facilities here to see what kind of impact we can make through FluFit. And we've already started adapting some of the materials in preparation for the vaccination arrival. And so these materials are available to anybody if you're interested. So on the left, this is an 11 by 17 flyer poster that folks can post at their mobile vaccination clinics as well as throughout their clinics. And then on the right, these are customizable return reminder postcards. So these are front and back, and they would be, I think, 4 by 6. And these are one way. Dr. Brooks, I believe, mentioned that you can almost get a double return rate if you use some type of follow-up as outreach. And so we've got these cards ready to go, and at the very bottom of them, under the thank you, there's a box, a fillable box that allows anybody to fill in, which clinic, they need to be returned to. And I think that's especially helpful in some of the mobile flu clinics when they might hold them in community settings, and maybe it wasn't as clear to the patient where the kit actually has to be returned to. So this is a nice opportunity to do some follow-up. And then finally, before I conclude my section here, I did want to share with you a few resources that we've developed here at our Tribal Epidemiology Center, most of which are available to you either electronically or in hard copies if you're interested. We did develop a series of provider detailing cards, and we did this in collaboration with our partners here at the New Mexico Department of Health Comprehensive Cancer Program to really make sure that we're communicating across all provider disciplines the current recommendations for screening for those screenable cancers. Here in the Indian Health Service Albuquerque area, we utilize the United States Preventive Services Task Force guidelines. We do have a flip chart that we utilize and that the CHRs utilize when they go out in the communities. It's a little bit oversized, but it fits in a patient examination room fairly nicely, or in a drawer. It can go in a backpack, and it can be carried out on home visits. So it's a nice visual way to show some of the key messages around colorectal cancer screening. We've developed some fact sheets here that really weave together some of the data and the patterns that we're seeing along with the recommendations for screening and prevention for cancer. And so we have 3. These are very specific to our area. We've completed several digital storytelling sessions where folks, including CHRs, are talking about their experiences in trying to promote colorectal cancer control in the community. We think we've developed the first FOBT testing video for American Indian. Within it, we can send out hard copies of the DVD. It's like a 10-minute motivational video that weaves together stories from 3 communities, including a colorectal cancer survivor who shares her story. It also, as you can see in the top right, it has a sort of instructional vignette on how to set up the toilet for any FOBT test. And then there's 3 different short instructional vignettes as well that show how to perform tests depending on the type of collection method. There are so many different FOBT and FIT kits out there, but what we have found is that most share some commonalities in terms of how you collect them. So we were able to distill as much as we could into 3 short instructional videos. And if you don't want to get the DVD, you can also just go to our website, www.tribalcolorectalhealth.org. And what this will do is allow you, if you look on the right-hand column under digital stories and videos, if you click on any of these items, it'll show up right there in the viewer. And at the bottom is the Caring Way as well. And the motivational video is the first, and then all of the short instructional videos follow. There's several other materials on this website, and we continue to put new information on here. We also have a poster and 2 brochures that we've developed. These are relatively new. Again, these are available for download electronically, or if you contact us, we can send you some hard copies. And then just keep in mind, too, we do now have those FluFit materials as well. So I encourage any of you to explore our website at tribalcolorectalhealth.org if you're interested in learning more about what we've done or viewing any of the digital stories. I also want to acknowledge our team here that was involved in the intervention that I just described, Amanda Chimslin and Jasmine Jacobs from the CDC Public Health Prevention Service and PHAP programs, and Donald Haverkamp and David Espy, who I'm sure many of you know, who are both here in Albuquerque and with the CDC as well. And there's my contact information, and I really appreciate your time and interest in this topic and look forward to hopefully hearing from you and answering any questions you might have. Thank you.
Thank you, Dr. English. If you would note over on the GoToWebinar control panel on the bottom side is a section called Handouts. There are 3 handouts there that are readily available for download. All you have to do is click them, and you'll find them in your downloads directory. Questions, question and answer. Any questions for Dr. Brooks or Dr. English? Robin, I can't see questions in my window, can you?
So the first question I see is there a preference for a FOBT test over a colonoscopy because of the prep needed for the colonoscopy?
I'm going to assume this is Durado Brooks. I'll assume that question's for me. We don't entirely know why patients have those individual preferences. I mean, some people are simply afraid of or repulsed by the idea of colonoscopy, of inserting a tube into something that most people view as a one-way exit. There are some people who are aware of the prep. There are some people who've heard horror stories about colonoscopies, maybe had a friend, acquaintance, family member who's experienced a complication. So there are a lot of different reasons, the prep being only one small part of it.
Thank you, Dr. Brooks. Are there any other questions?
This is Robin again. Okay, the second question I see is how often do FOBT or FIT generate a false positive? Probably for Dr. Brooks or either.
Guaiac FOBTs, well, truly completely false positives are actually infrequent with both. Guaiac FOBTs have a somewhat higher false positive rate, but Hemocult Sensa, with Hemocult Sensa having a higher false positive rate as well. But their false positive rate, where colonoscopy is done and absolutely nothing is found, is somewhere in the maybe 10 to 20% range. With FITs, their false positive rate is even lower because of the portion of the hemoglobin molecule that they look for. They have very high specificity along with their sensitivity. But even a false positive FIT or FOBT has now done a lot of good, because if that patient goes through a colonoscopy and absolutely nothing is found, as I stated, they don't need any other kind of colorectal cancer screening for the next 10 years. So you've essentially removed them from the screening pool. So it still is, in most instances, beneficial.
Thank you again, Dr. Brooks. Did you have another question, Robin?
Yes, I do. Okay, so another attendee says, I work at a health district and want to expand our services to include FluFit within local general practices. Do you know of any best practices to break into the clinical practices and work with doctors?
We have, the ACS has a group of primary care staff who work in communities around the country reaching out to primary care practices. I think the kinds of things that actually influence clinicians, if there's a way that you can get local data and show clinicians whatever the local screening rates are, help them understand that although they feel, most clinicians actually believe they're doing a much better job of screening than they actually are. So showing them that at least among their peers and colleagues what the screening levels are and how, in particular, some groups may not be getting screened. Also sharing information like that one-pager on stool testing that I mentioned in my presentation to kind of bring them up to date on the potential value of stool testing. There's still the perception that stool testing is a second-class approach to colorectal screening, and the evidence is clear that it is very efficacious. And then finally, sharing information with them about the patient preference issue and the fact that there are any number of patients in their practice who, doesn't matter how many times they offer colonoscopy, they're simply not going to accept it. So giving patients alternatives has been shown in a wide variety of settings to result in higher screening rates.
All right. Thank you, Dr. Brooks.
I was just going to add, too, real quick, I think another good point of contact when working with a primary health facility is if they have public health nurses or even just anybody in nursing, that's often a good source to begin your conversations, because I think they're always looking for ways to potentially increase their participation in not only flu clinics, but also colorectal cancer screening.
Thank you, Dr. English. I'd like to...
I'm sorry, one other
Go ahead.
In the references that I provided, there are actually, I believe I referenced a couple of articles that have been published showing the benefits of FluFit in primary care practices. So again, that's the kind of information that primary care clinicians may pay attention
to. Anything else you'd like to add? All right. Thank you, gentlemen. Thank you for your wonderful presentations today. I appreciate your time. Thank you for attending the National Native Network Technical Assistance webinar. Please watch for the evaluation survey, which will come to you by email shortly. If you are planning to obtain CEUs for this webinar, complete the evaluation survey in its entirety. Please visit our website, www.keepitsacred.org, to find this and other technical assistance webinars, as well as many other cancer and commercial tobacco prevention resources for tribes and tribal organizations. Thank you, everyone, and have a great day.